A meeting to order of the Delaware County Board of Health. I want to just begin with a couple chair announcements. We had an executive session on September 11th. I also want to make the announcement that we are presenting at the National Boards of Health Association in October, and we're presenting at the American Public Health Association in November, as specifically around the Board of Health and founding a new health department. Very exciting. They're my chair announcements. At this time, I'd like to allow for public comment on agenda items. Seeing nobody with public comment on agenda items, we'll move to the approval of the minutes from the previous meeting, which everyone should have received electronically. And does anybody have any questions on the minutes?
I have no questions and I call for approval.
Okay. Second. Okay. And all in favor?
Aye.
Aye. Okay. The minutes have been approved. And at this time, we'll have Laura provide us with the director updates.
Thank you.
Thank you.
A little bit, and I think Sean is able to, he'll pull up the slides. Great, thank you. Starting off with our mission values. I promised at our when we presented the budget for you for fiscal year 26 that I would share some information about the closeout of actual expenses for fiscal year 25. So this is just a summary there, so you can see this is really came in and what really went out, and where we still stand. So at this point, the county contribution is hovering around 2.1 million. We are still outstanding 1.6 million worth of invoicing. That's still working through the ranks. But you can see our total expenditures were 12.4 million, and total revenue was 10.
The ones that are outstanding, would that take away from the county contributions, or is that?
No, that's just of these grants, a lot of
grants.
it's
all grants. Okay.
Yeah, they're still coming in. So you can kind of see also, this is a specific focus on grants, specifically what's been spent and invoiced, and what's not spent. There is some carryover. That picture there. This is a little bit of what you were wondering about in terms of what was still owed and what we're looking for. This is a very strong attention for us right now, as we are in a situation with the state budget still not being passed. We're really very carefully trying to husband in as many resources as we can, while we can, but there's definitely still funding that we're waiting for from the state. That's that picture. The other thing I wanted to share was, just one day last week, September 18th, we had a prostate screening event in Yaden during the day, where we were partnering with Jefferson Kimmel, where they came with their mobile van, and we worked with them with that. And this is a video, and this is the video about that.
Last week, the Delaware County Health Department partnered up with Jefferson Health to provide over a dozen free prostate cancer screenings for Delaware County residents.
Today, we are here at Delaware County Health Department doing free PSA blood draw prostate cancer screenings.
Family history of it, lost uncle to it. And really somebody my age, 56 and getting older, but that's really important to know where you stand with regard to that.
For more information on our wellness and prevention efforts, visit delcopa.gov/health or call our wellness line.
And then in the evening, we did the Rally for Recovery in Sharon Hill.
Is challenging, and last week the Delaware County Health Department brought together local partners, support networks, and inspirational Delaware County residents to celebrate recovery and offer resources and hope for residents who may still be struggling.
Down here in Delaware County, we're a clean and sober motorcycle club.
The recovery is anyone can recover. If anyone tells you that you can't, that's just not true. Recovery hasn't been easy, but I'm still clean and sober, determined to stay that way.
I was able to do things I thought I was never able to do.
We're able to have fun and really do drugs at home.
Anytime you feel the pain,
That's an artist that volunteers to do recovery events. So she reached out to us, and she did a great job. And So that was two pieces of the day. And then also there was the Born to Thrive Maternal Infant Survival Equity Summit in Chester at the stadium. And as part of that, Rep. Curry and the Black Women's
Health Caucus.
Health Caucus had a policy committee hearing, and they was invited, the health department was invited to testify, and all of the folks that gave testimony are at that link. So yeah, it was an exciting day. More than usual in one day, but it just gives you a flavor of some of the work that we're doing. And what we're really excited about for the both the prostate event and the Rally for Recovery, both of those things tie to our community health improvement plan. So the prostate screening works into our chronic disease work group. Rally for Recovery is part of the work we're doing, whole person work group. And I guess our third work group is maternal, parental and infant health. And of course, that's the testimony. So working all the angles, we're trying.
I was just commenting because on the way in, did you see the thing about Mississippi?
No.
Their in-
yes, I heard that.
Yeah, the infant,
What
their
happened?
infant mortality rate is 10 per 1,000.
They declared a state of emergency.
Yeah, obviously our numbers aren't that bad, but they're way higher than we want them to be in Delaware
Yeah.
County as well.
So it's interesting that things that they're, the reason I brought it up is just some of the things that you guys brought up at that hearing are things that they're now trying to do. So interesting.
Nope, missed that piece of news. Other than that, I just wanted to touch on the consolidated report. Were there any questions or comments about the consolidated report information?
I just want to highlight the two things that I thought was interesting. One was the test and go, that's, doing well. And it seems like, especially the 69th Street.
Taking off, yes.
Yes.
Yeah, we were just talking about looking at the year. I know the year's not over yet, but we're planning ahead for the annual report in our leadership meeting this morning, and the advances with test and go and how incredibly impactful it seems like it's been at 69th Street Terminal. Really feel like a good success for the year.
Anybody else?
No, it's just your STI, HIV testing, and it looks like you follow up with treatment for all the people that you're expanding your testing. Okay,
Yeah,
great.
we treat for some of the conditions, but for HIV, we refer out.
Sure.
Yes, yeah.
It's interesting being at the correctional facility.
Yeah, I mean, that actually came up as a cost saving measure for the county because the county, of course, pays the operations at the prison, and it was a really growing healthcare cost for them was their STI testing. So by partnering with them and taking their results and work with our relationship with the state lab, we can have at least that testing cost the burden removed from the prison. But it does add a lot of work for us because then we need to process all the results.
Yeah.
We have to have our courier pick them up and do the processing. But
Yeah, that's awesome.
Yeah,
Oh,
great.
Oni, can you hear us? Is she muted her? Okay.
Maybe
Okay.
Did you hear only you could unmute by doing *6-7?
You should text me.
Okay, she unmuted.
she got it.
Can you hear me now? Hello?
Yes.
Yeah, we just.
Okay, yes, I'm here.
Just, I don't know when you.
I'm sorry. Yes, I'm traveling. I apologize. I tried to get on Zoom, it wouldn't let me. That's why I just dialed in.
No problem. You're here. And we were just reviewing Laura's director updates. So just wanted to see if you had any questions for Laura.
No, yeah, I heard everything. No questions.
Okay, thanks.
And the only last thing I wanted to highlight, of course, is that we are still very much in an area of flux with respiratory illness season. ACIP met last week. There will be some changes that will trickle down to our operations, including, the one combined children's vaccine that will not be available through the Vaccines for Children programs, our understanding. But we haven't gotten direct guidance about that from the state, but that's what we're anticipating. So we also have the latest work exclusion guidance for healthcare personnel with confirmed or suspected respiratory illness infections, which is a good step forward. I'm actually really glad to see that. And it's in the same vein that we're trying to treat COVID as a part of the family of respiratory infections, not any differently than influenza or the other ones. So I think that's one step forward, and then we'll continue to see how the vaccine information evolves.
And then the other thing that we were gonna just remind everybody that the governor.
Yes, no, go ahead.
So everybody's aware, the Governor Shapiro has said that Pennsylvania will be part of the Northeast collaboration for health. And so what that really means as far as like, again, for the while they can't influence the vaccines for children program per se, it still could mean that our Medicaid clients could still get the vaccines that the Pennsylvania Department of Health deems to be necessary. So that's all being worked on right now. And I don't know if anybody had any other updates. I was just on a call, so I wasn't sure.
I have a question about the MMRV. Was the health department giving the separate MMR and varicella anyway? Yes.
Part of the options.
Yes,
But
yes.
just like in a pediatrician's office,
Mhm,
we could
okay.
allow a family to choose, did you want the single one, or did you want the?
Okay. Where was it tend to be, was majority separate or,
I don't have that in.
okay.
Could look that up.
Mhm. And I noticed that you're going out the flu vaccination campaign. Just curious what you're going to be doing for the COVID vaccine campaign.
Given the uncertainty about everything, our community-based vaccination effort is going to be flu only. We did not buy private stock COVID. We just were unclear on who we're going to be able to administer to when we were making the vaccine purchasing. So yeah, that we will get some COVID vaccine as part of the 317 and VFC programs. And so our families that come to us for that vaccination program will still be able to vaccinate with COVID, but for the free, the drive-throughs and the other events, we will just have.
But again, on that, the governor with the Pennsylvania Pharmacy Board has allocated that we don't have the same restriction as other states on the COVID vaccines. So there's a standing order if people choose to get it.
Okay. Any other questions?
I know there was a lot
Yes.
stuck in there.
Yeah, that's great. Okay, so then we'll move into the presentations, and Dr. Rulan is up first, and I can give you the clicker.
I bet, you know.
Thank you for the opportunity. Just to share information and data about diseases severely impacting our county. The data is from the Pennsylvania Department of Health. So what I did, I put something together trying to tell you the story about some of these diseases. By no means every disease is included. It's just some of the ones that are causing significant amount of damage to our population. Let me see if I can make this thing work. So they'll go higher than Pennsylvania. These are rates, percentages, incidence, mortality, morbidity. Significantly higher than Pennsylvania, Delaware County compared to Pennsylvania. Let's begin with these ones, percent of C-sections, and then you can see the time, the years, all together in years to bring a more robust rate, fertility rate. But take a look at this one. Very low birth weight, less than 1,500 grams or 3 pounds and 4 ounces. Significant problem here affecting all the county, but more in specific areas. These death rates, adjusted death rates like stroke, adjusted death rates in the flu and pneumonia, we're higher than Pennsylvania. Breast cancer, incidence rate, which means the new cases. And of course, these, I tried to put together in a number of years. STIs, this is a significant problem. Chlamydia, gonorrhea, primary and secondary syphilis, and you're going to see a little bit more information about these in a few minutes. Hepatitis A and B, chronic incidence, and TB. And below it is the source of the information. They provide information in tables and PDF files, and I put everything in bullets to try to portray a story here. Now, this one is showing our county, Delaware County, comparing it to Chester County, neighboring counties, and Philadelphia. As you can see, red text means that it's statistically significantly higher. So when we compare one county against the whole Commonwealth, the whole county, that's what it means. So we are higher in a number of these indicators, and then you can see Chester County, some of them, and then Philadelphia. We look more than Philadelphia than Chester County. And if you look at this one right here, Lyme disease, look at, we're lower than Chester County, but again, the land area, forestation is different. And so it is lower for Lyme disease incidence in Philadelphia. And this is just to compare what's going on with our neighbors. Taking a closer look here, we look at chlamydia, gonorrhea, and syphilis. The problem here is that for three years consecutive cycles, we are statistically higher than Pennsylvania for these conditions. So this is something to look at. And the lower table shows 2024 data, the upper one's 2015 to 2023. But that is the main message. If you look at 2024, look how one of, for example, chlamydia is affecting more females. That's what you see the square. And then gonorrhea, more males, and so forth with the other conditions. And look at the age group. The square against 22 to 24 tells you that they are severely impacted more than the other age groups. And then when we look at locations, some areas in our county, well, they have a higher incidence and higher rates of these conditions. And to illustrate the point, I combine all three STIs, chlamydia, gonorrhea, syphilis, by zip code, 2010 to 2024, a lot of years, because we want a good, robust data. And if you look at these circles, the bigger the circle, the higher the number. And you can see where most of these circles, red circles, are located in southern Delaware County, closer to the Chester area, Trainer, Marcus Hook, and then you see a lot of circles close to Philadelphia, Upper Darby, and those municipalities. The table shows you the zip code and then the number of combined cases to illustrate where these problems are occurring. And you can see some of them in western Delaware County, close to Concord Township on the north. Because we're talking a little bit more about STIs, I decided to take a look at the kiosk, our kiosk, and by quarter, So I found this very interesting. When you look, and that's why it's highlighted in red squares. When you look from the first quarter to the second quarter in 2025, this is recent data, look how it goes up at the government center and the first one, at the Keystone, and then at the Yaden Center. All three sites showing an increase in the number of STI, HIV blood, and urine collection kits, the distribution of these kits from the first quarter to the second quarter. The third quarter, you're going to see a lower number because it's not over yet. That's why so I wanted to highlight because it confuses me, so I thought it might confuse other people too. So it's quite interesting that we show that progress in the number of kits being requested by our population. This is something that sometimes you're going to hear West Nile virus, and I look at the ones affecting the individuals in a severe way, causing meningitis and things like that. And I put together this map, of course, from the Pennsylvania Department of Health. But look, what darker blue is where you have more incidents. This is per year of new cases. And you can see the distribution, but you see a lot of that darker blues in the southern part of our state. In terms of Delco is number 3, going from the highest to the lowest in that southern eastern part. Philadelphia is second, and we're third. And then last but not least, I just wanted to show the triad in infectious diseases, also in chronic diseases. You need an agent, which sometimes it's a virus or bacteria or something that is affecting the host. We are the host. And then we have the environment. So you need all of these things to act together in order to have a disease or the absence of health. And what is very striking is that every time we look into these conditions, poverty is a major driver for many reasons. So I just wanted to highlight that just to remind people that it is a big problem, and if we want to change things, sometimes we have to change the root causes of many of these health and social conditions. And I think that's basically it. Thank you very much.
Thank you.
All righty.
Do you think that the,
Stay up there for questions, Victor. Yeah.
okay, so the increased testing, which is very good at the correctional center and with the kiosks, could that look like an uptick in disease when in fact we're just doing a better job of detecting it?
Well, and those were test kits distributed, not numbers
Not that-
of
okay.
cases. Yeah.
We do need to take a closer look to see if that is the case. But in general terms, conditions are improving all over. It's just that some areas are experiencing a disproportionate amount of burden. But it takes a lot to analyze all of these things.
Oh, sure, absolutely, yeah.
But it's a good thing that more people are.
It's fantastic. No, it's all good. It might make the numbers eventually look
Yeah.
worse, but they're better because you're helping them, you're identifying them, yeah.
Tested, and then you say, oh, wait, I think I need to inform my partner.
Absolutely, yeah.
So it helps.
Yep, absolutely.
And I want to point out, in the consolidated report, if you're curious, there is the data on the number of human cases of West Nile virus. So as of, now for 2025, we've just had one. Last year we had, let's see, 2 confirmed. Oh, that's right. So last year, that's what I was remembering. We had 3 in 2023. We had 5 in 2024. That include confirmed and probable. So we're running lower this year.
Yeah.
But
I also put series of charts 10 years of all reportable diseases, but I thought it was too long to.
Thank you, Victor.
And I got an answer
Thank you.
from our nurse supervisor for the personal health. She responded back to me during it. She said that we did mostly offer the RV, that we went preferentially, not for the children under 2, but above 2. A lot of kids were coming to us needing a lot of shots, and it was actually helpful to be able to give
Okay.
them, a combined shot like that. So this will be a change.
Okay.
And we had no adverse reactions from the children that we had administered it to. Okay. All right.
Good evening. I am Ellen Morphy, and I work as a contract project manager for the Health Department, working on 2 congressionally directed federal grants. And I'm here to talk tonight about one of the initiatives under one of those grants, a mobile health community engagement campaign. And we conducted that between March and July of 2025. The campaign's goals were to raise awareness about current and planned mobile health services that are offered or will be offered by DCHD, to gather input on mobile health programs offerings, and to strengthen relationships with partners and residents. Very often, community engagement campaigns are conducted really as focus groups. So they're geared in sort of an extractive manner to gain information from members of the community to use for planning purposes, which is great. The third goal here is an unusual goal for community engagement campaign. We really emphasize strengthening and building relationships within the community. We recognize as a young health department, it's beneficial in general, but in terms of mobile health programming, very often you're trying to catch populations that are in the gaps, and those populations are often hard to reach, hard to have sufficient trust. And we wanted to make sure that we're using this opportunity not just to gather information, but also to build relationship. The campaign, as I mentioned, was part of a federal grant. It's the Delaware County Health Equity Grant, which was and continues, it's been extended, funded through the Health Resources and Services Administration, which is part of the U.S. Department of Health and Human Services, and it fully funded this campaign. We decided to hire professional facilitators to help us engage the community and to just organize the entire campaign. We'd done a couple RFPs under the 2 federal grants previously, but we were targeting very specialized providers. So we targeted and invited people to consider bidding on those RFPs. Because community engagement work is something that is done by a wide range of providers, we wrote our RFP and issued it through the county's Penn Bids program, which disseminates that RFP to providers throughout Pennsylvania. And we garnered 17 proposals from that. It's more than we'd gotten previously for any of our RFPs. And after a rigorous review, we selected Community Capacity Builders, a provider out of Philadelphia. They were really standouts in the bidding in recognizing sort of the grassroots relationship component and the pitfalls of having a more sort of extractive perspective. So we really appreciated that. They seemed to understand what we were going for in this context, and we're really wonderful partners in this campaign. You can see some pictures of one of the sessions that we did at, this is at one of the facilities for the Chester Housing Authority. So our campaign reach, we did 45 listening sessions around the county. That included 228 participants from 91 different stakeholder groups. In addition to those scheduled small group listening sessions, we also did 7 community pop-up events. So a pop-up event, it's an event that's already taking place, and our facilitators would solicit members of the community to engage in surveys and questionnaires. They would also do fun community activities. They did coloring pages around the health department's coming Wellness on Wheels vehicle, and there were 94 community participants that completed surveys during pop-up events. a little bit more about who we worked with in terms of reach. We engaged grassroots community organizations, elected officials, service providers, and residents, mostly through the pop-ups and a couple targeted engagements where we were having a little less engagement in a particular community. So we worked on just sort of an open call to community members or through local community organizations that had a pretty broad reach so that we could make sure that we were getting a nice balance of people and interests across the county, as well as reaching some of the targets that we had in mind.
Ellen, when they CCB interviewed this board, was that considered a pop-up? That
was considered a listening session.
Okay, so you're one of those numbers.
That was considered a listening session. So the pop-ups, a couple examples of the pop-ups. So we did a pop-up at Booth's Corners on a Saturday. So shoppers of all different stripes, predominantly, drawing from the eastern side of the county. We did a pop-up at the Pride Fest in Upper Darby. We did a pop-up at the AAPI Festival at Rose Tree Park. We did a pop-up at the Delaware County Black Caucus's Men's Health Program. It was a dinner focused on jazz with a bunch of information and networking. So that's a smattering, that was in Chester, a smattering of the different types of events as well as the geography for those pop-ups. The initial proposal that came from community capacity builders had fewer pop-up events, but because we had already built such wonderful networks and relationships around the county, we did more of the legwork that they had anticipated doing to set up the listening sessions. So that freed up some hours to allow them to do a few more pop-up events. So it was a really wonderful synergistic collaboration. So what did listening get us? The information gathered and the relationships built or strengthened during the campaign will help DCHD build a better mobile health program because we know how to reach the community and we know what the community is most interested in. It will help us have a more successful program launch because we've garnered so much interest and already developed a lot of trust around the program. And it will allow us to plan for mobile health program future services more effectively, because it's one of the questions we ask people, what kind of services are you interested in? We did that in a couple of different ways. We did do some open question dialogue, as well as some more targeted sort of a pick list kind of thing to really help us hone in on some of the things that we had been hearing throughout the program. We did tweak the questions that we did in the community in the listening sessions throughout the programs. We were able to pause, reflect on what we learned, and really sort of hone what we'd like to continue to learn from the community and have them hear from us. So that community input included the preferred mobile health services and wishes for service enhancements. And those are the things that really fueled the three that I just mentioned before that allow us to set up and launch and improve more efficiently. Not only did we engage in conversations, by the way, this is a picture of the 33-foot Wellness on Wheels vehicle, a custom designed mobile health unit that will be the centerpiece of the mobile health program that DCHD launches. Not only did we have deep conversations, we left those conversations with commitments from community members. We received 69 commitments to partner. Those included 33 organizations that agreed to provide outreach or referrals for us, 40 who committed to hosting the mobile health unit at their site or their events, which is really critical for us to be able to disseminate the programming. 16 agreed to provide supporting services or resources. 26 offered to provide general or other partnerships. And also, the entire thing was in many ways also a networking opportunity. And the conversations that we had in the listening sessions ended up leading to a connection for a mobile health clinical partnership that the health department is currently working to develop. So there's many ripples, positive ripples that have been created, and we certainly hope will continue. Some of the tools that we have a very long and robust report that will surely not be collecting dust, but some of the highlights of things, tools that we'll be able to use to continue to make an impact in the community include quick reference guides for some of the key communities that we were targeting. And we have a number of these. We have more granular information, but this is a great way when you're just thinking about, oh yeah, what were the key takeaways for some of our target communities? We have a bunch of these that are super helpful. We also included in our deliverables is a database of 400 plus community members who we can continue to engage about upcoming DCHD mobile health programs. Not all of them were able to engage in actual listening sessions, but a lot of them wanted to and want to continue to engage on topics around mobile health, upcoming partnerships, and that sort of thing. So the conversations have led to some community improved strategies. What are some of those? One of the outcomes is a calendar of events. So it's a calendar of events that community members have specifically said, we want you here at our community event. We want to come and you to be present at these community events, or we know that our constituents, our clients, or our community would like to participate, have mobile health programming at these events. Oops, they did not mean to do that. We also have community approved communications and marketing approaches and methods. So we were able to hear from community members how they want to get messaging from us, which social media platforms do they want to use. They actually, in many instances, named by name, by organization, trusted community members that they believe would be great to advocate for and endorse the mobile health program to help create trust and excitement in target communities, both geographic and demographic and other ways to slice and dice that. We learned many factors to increase participation, things that would draw out different communities and different community members. And equally important, we learned of potential barriers to participation. So again, mobile health programming very often is trying to catch populations that sort of are left in the sort of in between the cracks, if you will, or in the cracks between programming. And those populations can be very reluctant to engage in receiving health services. And we were able to learn very helpful things that where people were really speaking about their community and what they thought would be potential challenges if we didn't effectively address them. We learned a lot about access considerations. The mobile health unit I mentioned, 33 feet custom built. It is an accessible vehicle, but we also learned about additional access consideration, whether that's equipment that will be put on the mobile health unit, whether that's ways to engage and market and communicate to populations that have special access considerations, as well as things to think about in terms of the siting of the mobile health unit. The siting was also something that we talked about in the barriers conversation. So that's really going to help us think about where to put that 33-foot mobile health unit. There's a lot of considerations there, but the human components were definitely talked about, as well as some of those access considerations. And then the community also, the communities that we talked to and people that we talked a lot about trust building strategies and gave us a lot to chew on. It was both helpful and validating that the most common piece of feedback given to develop trust with the community and what individuals would feel would help them feel trusting to engage in services with a mobile health unit. Number one was really just engaging in a professional manner. And number two was engaging in a manner that felt respectful to the community members, that felt very validating in the sense that we already know that DCHD is deeply committed to those things. So that was, like I said, validating, as well as many of the other details they provided were helpful as we continue to plan the launch of the mobile health program with that wellness on wheels at the center. That is what I have to share with you. Any questions?
I was curious, did they share what services they would like to see from the Wellness Mobile Unit?
Yes, we engaged initially we had more open conversations and we received unstructured feedback. And our consultants went through everything, provided a mid-program report to let us see the trends and patterns that we were receiving in these more open conversations. And what we decided to do about midway through that campaign was to refine those, not so people were solely given a, multiple choice kind of thing, but we continue to engage in open dialogue, as well as then also some targeted questions about patterns that we'd seen, about things that we knew we were going to offer, things that people had already talked about, and things that we narrowed down based on the conversations and likelihood of being able to offer. If we were to offer this in the future, which would you be most likely to engage in, or do you feel would be most likely for your community to engage in? And again, we have a very nice report. Community capacity builders did a beautiful job really taking that diverse information, again, much of it unstructured, and creating analyses for us. Their initial, that mid-campaign report, they alphabetized the feedback that they had gotten, and we asked in the final report that they put it in rank order, which they did. So we're able to really, we also have all the notes from the conversations. So we're able to look back and in many ways kind of recreate those conversations because they were very granular, but we also have them in a more digestible sort of data-focused kind of way.
So I guess what we're really looking for, what are they?
Yeah.
Oh, what are they?
That is not in your, I was just quickly browsing through the slides and I'm like, shoot, I guess that wasn't one we made a slide on. So
I don't have what are they on the top of my head, honestly, but we do have them. And Laura, what's the best way to sort of retroactively share that?
Yeah, we'll send the full report out after the meeting, but we definitely heard a lot about mental health service board. There was excitement around some of the harm reduction work that we're doing. People, when prompted, seem favorable about vaccination and blood lead screening, but I would say what you heard more spontaneously was more things around. That was my memory, Annie, of going back.
Absolutely. And navigation assistance was something we heard very often. Now, remember, Crozier closed during the middle of this campaign. So that really shifted some of the conversations, and there was a sense of urgency around, those gaps. So, but even before that, and I mean, most of us knew that was coming, but the general public wasn't always necessarily aware. There was continuing conversation about primary care, about mental health care, navigation, but there's also a lot of things, vision screenings and help with eye care, dental. It's long lists, and it's funny. There's reports we've continued to get. I've always wanted them to sort of have an executive summary, but there's so many chunks that are rich and so many sort of data sets that are useful. But we'll share that report, and we can flag specifically the question that you asked and where what page that's on.
I think we really had to struggle, and we saw this evolve through the length of the project, where we started out with, well, these are the services we know we can provide. Which of those do you want? Between what we heard back from residents, which was like, well, that's nice, but what we really need is this. So we really tried hard to frame, this is what we know we can bring early with this programming. And we want to hear, though, what else you might want that we can partner with others to bring.
Yeah.
There's another year on the grant?
This grant, we got extension through the end of this calendar.
We have a 6-month
but it's
extension.
really just wrapping up things. The money to do this work is pretty much at this point under HRSA done. We are now going to absorb the cost of programming and doing things with our department budget, and then we'll look for other grants if there's things we want to do that we can't fund.
Yeah, because I thought the mobile unit was actually to get things started. It's been 5 years.
Oh, I know. One of the things we had to be flexible about was when the grant came in, it was intended to really launch the program, but we still don't have the vehicle. We are hearing that it'll be by the end of this calendar year, but we had to use the funding.
I ordered it in COVID.
I know.
Yeah. I mean, we did a lot of work on balancing things during the engagement, sort of the expansion and contraction, balancing expansion, contraction in terms of like, what would you want, right? And balancing an expectation. I mean, the delivery date changed for the mobile health unit multiple times while we were in the campaign as well. And we're looking to build trust, right? And it's very often when you talk to somebody about something that's coming, they think it comes next week. So we had to be very careful about creating excitement and engagement, but also doing so in a way that was realistic and would not, was unlikely to, in some ways, undermine trust. You said, I said I wanted this, right? So we've done our best to balance those things in the way we ask questions and we communicated. And we also, there was always DCHD people present for all of the conversations. And, at the end, we would answer questions and clarify anything that really felt like it needed to be clarified.
I'm going to pull one thing out of the executive summary because I can't help myself. So that one of the things that people shared, that persistent health disparities, especially among people of color, immigrants, economically marginalized communities, and people with disabilities, have been exacerbated by closure. Like we said, we heard that DCHG's mobile health unit can help fill these critical gaps by offering vaccines, wellness outreach, blood testing, first aid, and stop the bleed trainings. Community members also expressed enthusiasm for future opportunities to screen for chronic diseases, high blood pressure and diabetes, and learning more about other health topics, including dental hygiene, navigating the health system, and insurance. So pairing services and information with take-home resources, supplies, and incentives.
Yeah.
Awesome. Thank you, Ellie.
Thank you.
You bet.
Oni, do you have any questions?
I do. Can you hear me?
Yes.
Hello?
Yes.
Okay, I'm sorry. I've been trying to be like, hello, hello, hello. I guess you couldn't hear me. I just was wondering about the feedback, and based on Victor's report with the data about where we're seeing I guess increase in different health issues, are we trying to look at how we could use that data to do some of this work in this unit? Because sometimes people don't know what they don't know, right? So as an individual, you could say, I need this, I need this, I need this, but we have all of this data that is showing where the needs really are. So are we using that data to try and do some of this work? And then also, I remember we did some needs assessments some time ago with listening sessions with community members. I remember mental health coming up and some of those other health issues coming up then. Are we using some of that information as well to try to figure out what would be sort of the top issues to include in this unit? I just feel we have a lot of data, and I'm wondering how do we pick and choose what's important? But are we using what's already available based on the data, or is it just from the listening sessions?
No, such good feedback, Oni. And we are trying to take both into account. And I think one of the areas in particular is marries well with what Victor presented on the STI side, where we're using a lot of the geographic mapping and information we have about where we have the most need to address STIs, and then can we fold that into programming that we're going to do in that vein with the mobile unit. So we are going to try to use both data and the insights from the engagement campaign to drive things. It's going to be hard to prioritize. We're really going to have to start smaller and then grow.
And just recognizing, we had target locations and populations in the listening campaign that were data-driven as well. So the synergy is there. I will say that we also had a few rich conversations about the comforts or discomfort around doing STI testing and treatment on the mobile health unit. Obviously stigma is a consideration, and being able to have rich in-person conversations about that to complement data is, a great opportunity to, wed those two differing perspectives that need to be considered so that we can, move the needle on important issues.
Questions? Great.
Good.
All right.
Thank you.
Final presentation is online, and you can see Bree, and I'll let you go for it, Bree. Thank you.
Hi, everybody. I'm just gonna move to share my screen here. How'd we do? Does that look correct?
Yes. Yeah.
Excellent. Just need to, there we go. Okay, so I'll be talking tonight about the findings of a preliminary readiness assessment that I conducted with the help of the department and some subject matter experts on the topic of public health accreditation. So this preliminary readiness assessment was conducted with the goal to explore feasibility and benefits of FAB accreditation. FAB is the Public Health Accreditation Board, so throughout the presentation I might say FAB. Provide an overview of the accreditation process and what that looks like. Inventory the required plans through the process and their current status within the department at this time, and to develop recommendations and next steps for the Delaware County Health Department. So what is accreditation? So accreditation is a voluntary, so it's not required, national program that's run by the Public Health Accreditation Board. It recognizes state, local, tribal, and territorial health departments that meet universal and common standards. And it's based on the 10 essential public health services. So the process looks like once we decide, if we decide that we want to approach accreditation, we apply for accreditation. We have to provide documentation. The FAB will conduct a peer review as well as a site visit and determine whether or not we meet the standards for accreditation. The accreditation process is 5 years. And so after that 5-year period, there is the requirement to become reaccredited. So the goal is really to stay active, and there's not really an end goal with accreditation. It's about the process and carrying it forward about that continuous quality improvement. So some initial benefits truly are accountability, quality improvement, consistency, stronger infrastructure for the health department, as well as increased public health value. It can also be seen as an accolade, but at its core, its intention is really to facilitate these benefits, the accountability, the quality improvement, consistency, sort of doing what we're supposed to be doing as public health departments. So a little bit more about the value of accreditation. Really, truly, it's about looking at core public health. It provides that accountability to fulfill the 10 essential public health services, which I'll go over shortly. And accreditation both prepares local health departments by setting them up with the plans and procedures that they need to meet the standards. And it also serves to hold them accountable by requiring them to complete annual reports and eventually to apply for a reaccreditation. And again, accreditation is not just an accolade to achieve, it's a way of operating. It's about doing what we're supposed to be doing and setting up departments to do so in a sustainable way. What does it cost? How much does it cost and where does the money go? So the Public Health Accreditation Board issues a fee schedule every year. So the current cost of accreditation is outlined in this slide. You'll see that the asterisks indicate required fees. So there's an initial readiness and training fee that is $1,299. It's a little complicated here, but if we apply within 12 months of applying for the readiness and training fee and paying that fee, a $500 credit is applied to the initial service fee. Each year, the cost is, the annual accreditation services fee is $11,200, and it's based on the population of the jurisdiction of the health department. And Delaware County falls into the 500,000 to 1 million population, and the fee for us would be $11,200 per year. There's no fee to reaccredit, and there is a cost to make an appeal if that is something that's needed, but again, that's not required. So over 3 years, the estimated cost is about $34,399. So where does that money go, you might be wondering. So those fees go directly to the Public Health Accreditation Board, and they support its operations, which includes the ongoing costs of accreditation and recognition processes, staff salaries for accreditation specialists and support teams, training for the health departments, as well as site visits by peer review experts. So these fees ensure that FAB can continue to provide those quality services to assess and recognize public health departments against those national standards for continuous quality improvement. There are 6 health departments that are accredited in Pennsylvania, and these include the Pennsylvania Department of Health, the Allegheny County Health Department, Bethlehem Health Bureau, Chester County Health Department, Erie County Department of Health, and the Philadelphia Department of Public Health. So I'm sure you're all familiar with the Foundation for Public Health Services, as it was the framework that was used with DCHD in mind as it was being designed. And so I think it's really important to point out that the public health accreditation process uses the Foundation of Public Health Services, and they're operationalized into the standards and measures that are used for National Public Health Department accreditation. They're the basis for pathways recognition and transformation. The foundational areas include, and I'm sure these look very familiar because it's the work that we do as public health: communicable disease control, chronic disease injury prevention, environmental public health, maternal, child, and family health, as well as access to and linkage to clinical care. So accreditation can be very confusing. There's a lot of words, there's a lot of language. So part of my goal was really to try to demystify the public health accreditation process, which can be overwhelming. And I think health departments, when they're first looking at this, can be really apprehensive. So regarding the language that's used, there's 10 domains that align with the essential public health services. And those are groups of standards that pertain to public health services. Below that, there are standards which describe the level of achievement that is expected for a health department, and then specific measures that describe the requirements that are needed to meet those expectations. For each of these areas, measures, and standards, and within those larger domains, the health department is required to submit documentation that serves as evidence that a health department performs the functions that satisfy the measure. So essentially, we've got these areas that we need to work in, right? And we've got these plans, we've got these policies. We need to demonstrate by providing documentation to the Public Health Accreditation Board that we're doing those things as a health department. So these are the 10 accreditation domains: conduct and disseminate assessments, investigate health problems and environmental public health hazards, inform and educate the community, engage with the community, develop public health policies and plans, enforce public health laws, provide access to care, workforce development, quality improvement, and evidence-based practices and research. So this is just a quick snapshot of what a timeline might look like for the Delaware County Health Department. By no means should the health department jump into this quickly and expect to be done, within 3 or 4 years. Truly, it's about the process itself. The process itself is going to be just as beneficial as being accredited, receiving that accolade. So because the community health assessment was completed in 2024, and the community health improvement plan is completed in 2025, that's where we started the timeline. So for each of these domains and the documentation that's required, there's a specific look back period that the Public Health Accreditation Board asks for. And typically that's between 2 and 5 years. So say, for example, measure 5.2.1A is, it looks at the community health improvement plan. And the look back period for that is within 5 years. So for the community health assessment and the community health improvement plan, we need to show evidence that occurred within the last 5 years, looking back from that point at which we apply for accreditation. So say, for example, we're applying for accreditation in 2029. We can look all the way back to that 2024 community health assessment, and that will count as evidence that we can provide for that documentation, as well as the community health improvement plan. So if we were to go about doing it that way, we would work to complete emergency operations plans in 2026 and 2027, and then begin to participate in the FAB readiness and training program in 2028. In 2029, apply for accreditation, submit all documentation during that year, and then in 2030, there will be a formal review by FAB. So this is by no means a quick process. And that's okay. It's really truly intended to be about quality improvement. And if we're doing it right anyway, like if we're doing the things that FAB is asking us to do in these domains and these standards and these measures, the look back period shouldn't matter that much because we're supposed to be doing a community health assessment every 5 years, every 3 to 5 years. We're supposed to be updating our emergency operations plan, and that's what it's all about. So these are the 8 major required plans that are included in the process. The community health assessment, which has been completed, the community health improvement plan, which was completed, the strategic plan, which was completed, workforce development, emergency operations, organizational branding strategy, quality improvement, and performance management system. So you can see that the status is listed for each of these, as well as the date that it was completed or the current status. So at this time, of the 8 plans, there are 3 that have been completed, 3 that are underway, and 2 that are not yet started. Some of these are pretty close. Like, for example, the organizational branding strategy could take just a week or 2 to make those edits, and it would be ready to go, right? Emergency operation plan needs a little bit of work to align it with the FAB standards, and to sort of go beyond that medical countermeasures plan, which is quite good. So there's areas that are going to take more time than others. And the reason beyond these plans, so these are the 8 major plans, beyond these plans, there's also a number of other documentation pieces, policies, procedures that need to be demonstrated, but these are the ones that take the most time. So they're the ones that we want to make sure that we're focusing on to begin with, because it's not, these aren't quick things. It's going to take several years to make these happen. And I think considering the fact that, like Ellen said, it's a young health department, the fact that we have 3 completed, 3 underway, that's phenomenal for the age of the health department, truly. So next steps for DCHD, if this is a road we want to go down, is to develop a FAB orientation and communication plans, primarily for the department, for the managers, for the staff, for the people who are working with our clients, making sure that they understand that FAB isn't about the accolade. It's not about getting the medal and hanging it up in the office. It's about developing these plans and procedures that we should be doing anyway. So regardless of whether or not you decide to go for accreditation, focusing on those 10 essential public health services and completing all those 8 required plans is not going to do anything but help to improve the department. So again, completing those 8 required plans, consider hiring or designating the role of accreditation coordinator as one's sole responsibility, establishing a FAB committee. So that would be inside the department, having somebody from each division be a part of that. So everybody as a team begins to understand the purpose of accreditation. And again, because it's a young health department, there are many plans and policies and procedures that need to be established. Those should be established with FAB in mind, with the essential services in mind, with the foundational frameworks in mind. And those FAB committees would then cross-reference plans with those FAB standards and measures to assure that alignment exists from the beginning. So as they're developed, so we don't have to go back and retroactively change things should you decide to go for accreditation. And again, biggest thing, don't stress over those timelines. This work is about best practices and not achieving accreditation in and of itself. And I think that's my last slide. Does anybody have any questions?
Yeah, so thank you for the presentation. It's interesting that only a handful of the health departments in Pennsylvania are accredited. Do you have a national picture of accreditation throughout the United States?
I do. I can pull. Do you want me to pull that up while we're talking?
Yeah.
Or do you want me to?
Yeah. It's kind of interesting that, as I stated, very few are accredited in Pennsylvania.
Well, keep in mind that there's only the 11 departments, so I think we've got 4 out of,
Okay.
It looks on the map, it's like, there's so much of the state isn't covered by a local health department.
Right. So, and most of them have been COVID messed a lot of the accreditations up that were in the middle of happening.
Okay.
At the time, and because of variety of factors. Yeah, so there's 406 local.
So this is the map. Gosh, I wish that I can click on each state.
Okay.
But overall, Hopefully I'm not making you dizzy over there. Overall, there are 40 states that are state health departments that are accredited, 406 local health departments, and 8 tribal health departments that are accredited.
Well, I should point out that when we were establishing the health department, this was one of the accreditation was one of the key things that was identified as part of our strategic plan for the health department initially. So I know council has always said that that has been a goal of establishing the health department and having it accredited. Now, they had a more ambitious timeline, which was 2028, but they, as you pointed out, it's more important that we do this right. And the good thing is, because we were new and we were building the health department, we really tried to make sure that the, as we were building it, as you did the chip and the chaw, that they were meeting the accreditation standards for doing that.
Absolutely.
Yeah.
And I talked to a few subject matter experts while I was conducting the assessment, and they are the ones that really stressed that you don't need to push the timeline. You can if you want. If you want to be accredited right away, that's great. It looks good for you. It looks good for grant applications, for collaboration with governments at multiple levels. But really, truly, the purpose of accreditation is doing the right thing, right? It's about making sure that we are, as a health department, fulfilling our duty as a health department, making sure that we're meeting those essential services and that we're doing so with the community in mind. So if we're doing that, I mean, we've met the goal, right? Like, we're becoming accredited. We're practicing what we preach, and we're practicing, what the gold standard measures are saying we should be doing.
It's noted that you're recommending a coordinator. Do we have that funding for that coordinator?
You know, the Public Health Infrastructure Grant, FIG grant that the health department has, we've carried along a position to fill that. So, as long as that grant is, I think we're in the third year of a 5-year, it is there with that grant. I don't know what's going to happen in this current climate, whether that will continue. So we've reserved it, but we haven't acted on it. And
with the hiring freeze, it would be. Yeah, okay.
Yeah.
That's.
So I think also, like when you apply for accreditation, they want to see that you have a specific person who's working on accreditation and that's their job. But if you think about it, pieces of what's required for the FAB are sort of considered FAB work. So if I think about like quality improvement, for example, or the community health assessment, community health improvement plan, working on those plans, working on conducting quality improvement are all parts of public health accreditation. So in my mind, if I was trying to decide how I would do this, I might incorporate quality improvement into that FAB coordinator role, and sort of seeing that as you probably have a desire to have somebody who's doing that quality improvement work anyway. So if you're able to marry those concepts, it might be a good opportunity to achieve both goals.
Definitely. Yeah, that's exactly where my thinking has been. To answer your question, Lily, that there's like 3,500 local health departments.
Okay.
So the number she flashed up there, it's like about 11% or 11 to 12% of those local health departments are accredited nationally.
How low it is,
So I think it's interesting because I worked at a local health department for 14 years in New York State, and accreditation is relatively new. We started talking about it maybe in 2009, 2010. And at that time, as a local health department, it was like, is this worth it? We had to pay money to do what we're already doing. I think that it was sort of, there wasn't really a great understanding of what it was. And I think we were also, as a health department who'd been operating for a very long time, still in that public health 2.0 model, not yet moving into that public health 3.0 model. Our state was accredited as a health department, so we had their guidance and support, but we never actually approached accreditation. And the more I learned about accreditation, it's really changed my mind about a lot of things. Again, it's really truly not about that accolade. And I think that's where the directors in my state, in my region back then really saw it, what they saw it as, and not necessarily as this performance improvement strategy for the department with the goal of improving public health value. I don't know if that's helpful.
That's what the original steering committee for the health department really emphasized, trying to have it accredited as building it in and doing everything right from the beginning.
And I feel like we've really been able to take advantage of that. I mean, that was one of the things that Melissa, the first director, brought, was that experience with it, of coming from a department that was accredited. So a lot of the foundational things that we have are there, you know, but we also can see, especially as Bo's process working with you, Bree, I can see the things we don't yet have.
Right.
And I still want to get to. Do I need accreditation to get there?
That's
I
what
don't
I'm.
know, you know, but that's why we're having this process and this discussion.
Mhm.
And some of I spoke with a few, I'm sorry, I don't mean to interrupt you. The other thing I was gonna say is I spoke with a few different health departments during this process as I was looking at this, and they said, I proposed that idea, Laura, of could we just do what accreditation says to do and then not get accredited? And absolutely you can. But what they said that they felt was the most valuable was the accountability, like having to report to somebody, making sure you stay on track.
Yeah, yeah.
I
Gee, it's kind of like how you've been working with me on the code review.
Right. Yeah, no, I agree. I think accreditation is important because it keeps everybody accountable. To a timeline, to making sure things are happening on time, and but not at the same time, not worrying so much that it has to happen by 2030 or 2028, but that it's moving forward, because it's easy to put things on the back burner. But I know there's a lot going on, and funding issues are certainly a concern, so it all has to be balanced. But I think we move forward, keep moving forward with it.
I feel far more prepared to think about how this would work, thanks to all this work, Bree, that
Yeah,
you've done. So
no,
thank you.
it's really helpful. Thank you, Bree.
Thank you.
You're welcome.
All right. Anything else from anybody? Oni, anybody else?
Wondering, is there anything that if the federal government shuts down next week, the ripple effect on your day to day, or you're just living day to day at this point?
It's like a new insult to injury, and I do think that it could delay some of the reimbursement work that under the federal grants that we have.
Yeah.
Further exacerbating the cash flow problems that we're already experiencing.
For the county,
Yeah,
because the state doesn't have. a
because the
budget.
state hasn't passed its budget,
Yeah.
so yes, it will not help.
Yes.
Yes.
Sorry.
Yeah. And I think there's just so many unknowns, with the vaccine policy and then other things coming out, that everybody's just kind of like.
What
doesn't know
else?
What to do.
What's next?
Yeah, I think we're all just in a holding pattern until
It's passed.
it's passed, or people figure out what policy we have for public health. But the other thing that will be interesting, if the state does have, is part of this Northeast Coalition, then, you know, that could change, like then that could even impact what the federal government would be willing to be reimbursed. There's all kinds of interesting policy twists to it, so. All we can do right now is just keep moving forward like the world is perfect.
Got important things to do. We're gonna keep trying to do them.
Yeah, yeah. So I don't think we have any public comment, so nobody's here.
Nobody on the phone?
I don't think we can do the phone.
Oh, okay.
So,
than Oni.
except Oni, if
Okay.
Oni had anything she wants to say. Our next meeting is December the 4th.
Okay.
And that will be our last meeting for this year. Just as a reminder, at the December 4th meeting, we will, two big things have to happen. We have to approve the calendar for next year.
Okay.
And we also have to submit the nominations for the 3 board positions that expire in 2026.
Yep, so we started that process with the county, that will be advertised through their process, and then we'll go from there.
Yeah, and the current board members also have the opportunity to reapply. Okay. All right, so that's everything. Can I have a motion for adjournment?
Okay.
All right.